All right, let's get started. We're recording now. So let me just pull up this other screen. I appreciate everybody that's here. Or anyway, thank you for coming. I appreciate it. Okay, let's get started here. So this is the LSRT study group number 8. Uh, we're going to talk a little bit about radiation safety today. Uh, Radiation safety is pretty cool, so there'll be a couple lessons on this going forward. Um, but yeah, let's get this started. We're going to review a little bit about what we talked about last week. We talked about radiobiology, how radiation affects the body once it enters the body, and the effects that can happen. Um, let's talk a little bit about that. So we talked about deterministic effects, which refers to a predictable outcome or effect of certain doses of radiation. It occurs when enough radiation energy disrupts tissue, so it causes problems. Stochastic effects, and this is probabilistic. That's a hard word. Uh, these are effects that happen just merely by chance. They don't happen to everybody, but they do happen. The probability of this effect increases as the dose increases. So we also talked about somatic effects of radiation. Somatic effects is when a dose of radiation interacts with the body and it actually causes damage to that cell. That is what we refer to as somatic effects. Um, Skin redness, burns, acute effects, nausea and vomiting, hair loss, fatigue. These are the bad things, and this isn't something that we're going to usually deal with in the type of X-ray that we do. This is more radiation therapy, cancer treatment, or Chernobyl type events. So let's run through a few of those just so we're aware of what they are for testing purposes. Radiation sickness, it's a real thing, and it's not something that needs to be taken lightly. So weakness and fatigue, confusion, nausea and vomiting, vomiting, blood, diarrhea, rectal bleeding. Those all sound fun, right? Fever, skin tenderness, swelling or burning, and hair loss. Those are acute findings in radiation sickness. So again, with somatic effects, later long-term effects, which is more what we will see if we do or if we're exposed to radiation for a long time. This is some of the stuff that may occur. Increased risk of cancer, thyroid cancer, leukemia, and cataracts. Organ damage, depending on the area that's exposed. Fibrosis, and when those organ tissue or tissue becomes fibrous, can be very dangerous. And impaired cognitive function. Those are some long-term effects that happen due to overexposure to radiation. We talked a little bit about tissue radiosensitivity, what tissues are more sensitive than other tissues. We learned that more prolific the cell is, or the more it divides, the more sensitive it is to radiation, i.e., embryo cells, the baby growing in mommy's tummy between weeks 2 and 8, very sensitive because there's a lot of cell division going on there, and the more that cell divides, the more sensitive the tissue is. So just keep that in mind again for testing purposes. We also talked about SI units. Units for measuring dose exposure, REM, RAD, sieverts, columns, things like that. Just be familiar with those. You don't need to know what they do and all that, but be familiar that that's what they are. The REMs, the RADs are more traditional. measurements of radiation, where the sieverts and columns are more modern or modern SI uh, measurements. Uh, so it just says here, pay attention to the areas that we are imaging and protect those areas, people that are more sensitive. So, we need to know who those people are. And we know that just by studying that young women of childbearing age 12 to 50 are more sensitive, and we need to protect them. We need to protect kids. And anybody that wants that protection they can have that protection. So don't be afraid to use it. Radiology has come a long ways in doses versus image. So, radiation protection as far as lead shielding isn't as important as it used to be. But in my mind, if somebody wants a shield, you let them use a shield. And if they are, in that state, being pregnant or childbearing years, we need to cover them up. Okay. All right. So let's talk about some radiation protection stuff. So, minimizing patient exposure, and you're going to hear this 10 dozen more times. ALARA, you'll need to know what that is, and you'll need to know what this acronym stands for. And it stands for as low as reasonably achievable. And of course, that's talking about radiation dose. We want to keep it as low as we can and still get a diagnostic image. So we're going to talk about exposure factors a little bit. KVP, kilovolt peak, we deal with that every day. We need to know what that is, and we've learned in the past few weeks that kilovolt peak means the quality of the beam or the average energy of the X-ray beam, right? Okay, let's talk a little bit more about KVP. It determines the quality of your beam, okay? X-ray penetration is governed by the KVP setting. So whatever we set our KVP at, that is going to be the energy of our beam. So KVP controls the contrast of the radiologic image. Okay, lower KVE, high contrast, high KVP, low contrast. Okay, so if we want to take a picture of a hand, we want really good contrast between soft tissue and bones and different attenuation of bones. We're going to use a lower KVP, i.e. 50 to 55, 60. Whereas chest x-ray, we're looking more at lung tissue. So we want less contrast. We want to be able to see the differences in the shades of gray, and you'll hear shades of gray a lot. That has everything to do with KVP. Okay, so we're going to use a higher KVP. Higher KVP equals lower contrast, and vice versa. Okay. Let's see. Contrast is the difference in density of adjacent structures on an image, and we talked about how that works. Kind of is radiation goes through the body. There's an attenuation that happens. Where more radiation is absorbed, so that picture is going to be lighter once it hits the image receptor. So we know that bone is light and air is dark, okay, because there's more radiation making it through to the image receptor, making that dark, where bone is absorbing that radiation, so less photons make it to the image receptor, thus making the difference in tissues. So, okay. All right. So mass, what's another thing that we deal with? Mass is milliamp per seconds. So it's actually the milliamperage times the time, times the exposure time gives us our mass. Okay. And we know that mass is the quantity of the photons or the number of the photons that is produced and sent to the patient. Okay. So it's, number of photons delivered. MA is the tube current. Okay. The S is the length of time the X-ray tube is activated. Okay. So we hit the prep button, we hear the rotor start going. Okay. Once we hit expose, that beep is the amount of time that we're able to produce the X-ray photons that we need. Okay. And, when we set our mass or our milliamp in time, that is the duration of our X-ray shot. Okay. And that's going to make more and more sense as we go forward and talk more about that. Okay. So we know that the KVP and mass are both controlled by us, the radiographers. So we have everything to do with that. Okay. All right, let's talk about beam restriction a little bit. Now, beam restriction is a big part of radiation protection. Okay, and I think you guys are learning that as we go forward. Techniques and devices used to limit the size and shape of the X-ray beam. Okay, reducing unnecessary radiation exposure and improving image quality by minimizing scatter radiation. Okay, that's beam restriction. There's three different types of beam restriction. Aperture diaphragm, which is a little hole, right, in the X-ray tube that allows X-rays to come through there. Cones and cylinders, you see that more with dentists' office. You know, they have that big cone that comes up the side of your mouth and reduces the amount of radiation that you're getting to the amount of teeth they want to see. And variable aperture collimator, that's what we use in all of our Sterling clinics. We use a variable aperture collimator, and it has a little picture of that down there, what exactly that is. You know, the variable aperture is more user-friendly. We get more work out of it as far as collimating to an image that we want to collimate to. It gives us a lot of latitude as to how much radiation is going to reach that patient. So we use the variable, and like I say, cones and cylinders, more dentist type collimator. Okay, and then the aperture diaphragm is old school. You don't see them anymore. So let's talk a little bit more about occupational considerations for radiation safety. And we've got a little depiction down here. Less time near the source, less radiation received. Okay, that makes sense, right? So the less time you're around that X-ray tube when it's being activated, the less radiation you're getting. Okay. The greater distance from the source, less radiation received. Okay. And when we talked about that a little bit the last couple of weeks with the inverse square law, right? The further you are from the source of the X-ray, the less radiation you're going to receive. Okay. Behind shielding sources, less radiation received, and that's pretty self-explanatory. Which we should be behind that radiation shield every time we take an X-ray, unless it's absolutely necessary that we're out there. At which point we should shield ourselves, because we, as occupational workers, we do run a higher chance of radiation borne illnesses. So take care of yourself. Okay, let's talk more about collimators and the variable one more, because that's what we use. Okay, we use manual collimators. It uses lead shutters to enlarge or reduce the X-ray field. Okay, yeah, if you look up in there, if you get up under there and look, you're going to see metal shutters that come in this way and come in this way, and that's how we gauge the amount of, not the amount, but the size of the X-ray beam that we want to use. They're designed to minimize radiation leakage and protect the patient and the operator, which is exactly what they do. By limiting the size of the X-ray field, the amount of scattered radiation is reduced, which can degrade the image quality. And you know, I've talked about this from the very beginning. When you don't collimate, your image struggles, because we learned about scatter radiation and X radiation. Mostly Compton scatter leaves the body, and you know, at the angle it comes out, and it can go back into your image receptor and degrade your image, right? That's the necessary use of collimators. Okay, we need to collimate to the body size that we're shooting. It'll make a better image, plus you're protecting yourself and you're protecting the patient as well. So yeah, it says that this results in a clearer, more defined image if you collimate. Okay. Collimators ensure the X-ray beam is directed towards the region of interest, allowing for precise and quality imaging. Okay, if you break it down to the nuts and bolts of collimation, it's pretty self-explanatory. We're going to collimate to the body part, and only that window of X-ray is going to hit the body. Okay, now what it does after it hits the body is a different story, but the more we can reduce that, the less scatter there's going to be, because the metal shutters actually absorb some of the weak X-ray photons, so it's not even going to reach the patient. So collimation is very important, and I know I talk about that a lot, but we need to use collimation to our advantage. Better our images are going to be, and the less exposure your patient's going to get. So yeah, if you guys ever have any questions about collimating to body parts, please let me know. We can definitely go through that, and we're doing that a little bit in the positioning films or positioning videos, as far as how to collimate to the body part that we're trying to produce an image on. Okay, so patient consideration, having to do with radiation safety. So proper positioning is imperative, and the reason it's so important is if we don't properly position a patient, we're going to miss the body part that we're trying to image, right? So what are you going to have to do? You're going to have to retake that image so that entire body part is included. So you're giving that patient twice as much radiation as they actually need. That's why it's so important that we learn how to position well, and we learn how to collimate well, so we're not cutting different body parts off, and we're able to see the parts of the body that the provider would like to see. Okay, so under collimation not only over radiates the patient, but due to excessive scatter radiation, it can degrade the image quality, and we've talked about that to nauseam. So patient communication is almost important. Try to give your patients clear and concise instructions on what you want them to do. I know it's hard when the patient can't hear very well, or you're doing a chest x-ray and you want them to take a deep breath in and blow it all the way out, another deep breath in and hold it in. Okay, it's much easier if we discuss that before we take the image. Just say, hey, I'm going to have you do a breathing technique with me. I'm going to have you bring in a deep breath, blow it all the way out, bring in another deep breath, and hold it. Okay, so when I say to hold it, I need you to hold it. That's going to save some image quality issues if you explain that to them before you actually do it. That way there's no confusion on what the patient needs to do, and you're going to get a better image because of it. So as far as holding a body part in the right angle or right position, if you maybe practice that with your patient before and let them know that's where you want it and that's where you want them to hold still, they're more likely to do that. So let's see, use lead productive layers or lead aprons. It's very important, especially when imaging children, pregnant women, or women of childbearing age. Okay, take care of them. You don't want anything like that to ever come back on you. If you image a pregnant woman and she comes back, baby has a birth defect, even though 99.9% of the time that has nothing to do with the radiation she received, that could come back on you. So, get your waivers signed, pregnancy waivers, and cover them up when you can. So, using proper technical factors for the size of the patient will reduce retakes and will reduce quality images. Okay, and going forward, we're going to talk more and more about changing your techniques due to the size of the patient, and it's going to make more sense to you. I know I had somebody ask me yesterday I don't understand the KVP and the mass, and we're going to get there. Like broken down to its nuts and bolts, it's pretty simple. But we're using a different technique, whether we're imaging a 120 pound woman or a 400-pound man, there's going to be a huge difference in technical factors that we use. Okay. Um, we need to have enough oomph to get through that body part and show an image on the image receptor. And, unfortunately, that means that we're going to have to make some changes to our mass or our KVP. And we will talk more about that, and it's going to make sense to you. But proper technical factors are very important. I've had various people call me in the middle of the day asking what kind of technique they should use on a patient that weighs so and so pounds. And that's the first thing I usually ask is how big the patient is, how tall, how much do they weigh. That'll give me a really good idea of what kind of technical factors we're going to be using. So please don't hesitate to call me, and if I don't answer right away, I'll get back to you as shortly as I can. But I can usually get you in the ballpark as far as getting a reputable image to be diagnostic. Please don't hesitate to reach out to me if you have questions. You've got a 400-pound dude in there and you're doing an L spine on him. Yeah, you're going to use a lot of technical factors. So yeah, don't hesitate to reach out. And the more we go forward and the more you study, the more this is going to make sense to you. So we talked about ALARA before, as low as reasonably achievable. Next week, we'll talk a little bit more about this. The three major components to X-ray radiation safety is time, distance, and shielding. Okay, and I'm going to add to that technical factors. They're all very important as far as dictating what kind of radiation dose you're giving your patient. But always remember ALARA. It's going to be on a test, I promise you, and it's going to ask what it means. So as low as reasonably achievable. So as low of a technique as you can use and still get a good image. There's a fine line there sometimes. Okay. So let's talk a little bit about filtration. We talked a little bit about this. Filtration is the X-ray beams reduces the amount of low energy photons that come through the tube. Okay. Effectively hardening the beam. Okay. Making the beam more efficient is what that means. Which image quality and reduces patient dose. Okay. So inherent filtration. So every X-ray tube has inherent filtration just due to the components that it uses, such as the metal housing that's going to protect us from leak radiation, the glass envelope, and the oil enclosure, the cooling oil. That's all there for our protection, and that's inherent. That's what they call it. So it's there and it's going to do its job. So we know that that fact is inherent. It's going to happen. So it helps filter out less energized photons. Okay. With the age of some tungsten metal, some tungsten metal, and we know that the tungsten used in the filament when we superheat it to let the negatively charged electrons go over to the anode. Okay, we know that that's tungsten, and also the anode plate where the electrons come and hit that plate. This is tungsten. Okay, and as that tungsten gets older, some of that tungsten will actually vaporize and move its way out to the glass envelope and stick on the inside of the glass envelope. If you see a well-seasoned tube, there's going to be darker parts and lighter parts. This is just vaporized tungsten coming and adhered itself to the inside of the glass envelope, and that's actually making it more safety conscious material. So the inherent filtration of a general purpose X-ray tube is approximately 0.5 millimeters. Okay, and you'll learn going forward that the lead shields that we use, the lead aprons, have to be at least 0.5 millimeters thick. The NCRP, the National Council on Radiation Protection Measurements, recommends 0.25 millimeters of aluminum equivalent. So where ours are 0.5, we're good that way. Just remember that filtration is the machine's ability to absorb lower energy X-ray photons. So it's a protection, the inherent protection of the X-ray tube. Okay. All right. So post-patient filtration. So this is a filtration that occurs after X-rays have gone through the patient, right, and go down to the image receptor. So X-ray grids. Now, in most of your X-ray rooms, especially the Paxis rooms, you're going to see a metal plate that actually fits inside the collimator. It kind of looks like that. That is a grid. So as what a grid is, it's an anti-scatter metal, okay? And it's made up of lead lining, okay, lead strips that absorb radiation. So that's what it does, is it absorbs unwanted radiation, makes your picture a little bit cleaner, okay? Stationary grids is what we use. You know, they don't move, they're just there. We take our picture, goes through the patient, and those grids actually clean up a lot of scatter radiation we get from our patient, and keeps that out of our image. So the bigger the body part, the more you need a grid. Anything over 4 inches, you should be using a grid. So just remember that rule of thumb, 4 inches. Moving grids, we just don't use them in the Sterling clinics. Very interesting. You'll be standing there taking a chest X-ray of the patient, and you'll actually feel that grid go back and forth. And what it's doing is it's trying to pick up that scatter radiation and also blur any radiation that gets through there to our image receptor. It cleans up our image. So just remember that grids are there to clean up our image. Okay, make our images look a little bit better because it's taking away the low energy scatter radiation that gets through the body. Okay, so now you know what that metal piece is. It's a grid. Okay, grid ratio refers to the height of the lead strips and the distance between them. Okay, so most of the grids that we use are 8-to-1 grids. They go all the way up to 16-to-1, 32-to-1. The more the grid ratio, the more it's going to clean up. But I'm pretty sure the ones we use here at Sterling are 8-to-1 grids. Okay, so the higher the grid ratio, the more scatter is absorbed. Grid cutoff, and you'll see this every once in a while on an image. It'll look like there's lines in your image. That's just because your X-ray tube isn't quite lined up with your grid. Okay, those have to be pretty perfectly lined up in order not to get grid lines. So if that ever happens and you say, hey, why does my image have lines on it? It's just because your X-ray tube is probably a little bit off center. Okay, so it's not going directly into the image receptor, and it's picking up those grid lines and portraying them onto the image. Okay, grid frequency refers to the number of grid lines per inch, i.e. 8 grid lines per 1 inch. Okay, that's what 8-to-1 means. Okay, we're not going to get too deep into that. Just suffice it to say that grids help clean up your image. Okay, and that is what a grid looks like. Okay, let's talk a little bit about image receptors, and then we'll get out of here for today. Okay, so we use digital image receptors in all of our clinics. And this is a device that captures and converts images into a digital format. Okay, the PSP, the photostimulable phosphor, we don't use those in any of the clinics, I don't think. Anyway, just uses a phosphor plate to store a latent image and then convert it to a digital image. You actually put it in a I can't remember what it's called, a reducer, but it takes that image and converts it to a digital and puts it on your computer. Okay, now ours are our CCD coupled device. solid state receptor that directly converts X-ray into an electrical signal. So we take the X-ray and bam, it's on the computer screen. Okay, there's no middleman or anything. That's pretty awesome, actually. So computed radiography uses PCP plates, which we don't have in any of our clinics. So just suffice it to know that what that is, computed radiology, and it uses PCP plates. Okay, DR was what we use. DR is digital radiography, or DDI, same thing, direct digital imaging. Okay, we use the CCD charge coupled device. Okay, it's the one that uses CCD sensors, the X-ray captured directly, and is digital as a digital signal. So there's no lag time there. You don't have to put that cassette into an image receiver to get that to convert over. It does it automatically, which is just totally awesome. You take your picture and there it is. The advantages of digital radiography, there's no dark rooms. I spend a lot of time in a dark room, and they're not fun. The chemicals stink. Yeah, not a fun place to be. So we don't even have to do that anymore. Our images hit a sensor and are sent to the computer, and there it is. Okay. It also improves the quality of the image. We have to use less radiation to image this type of image receptor. And then once that image is on the computer, as long as we've used enough technique, we're going to have a lot of latitude to change that image to make it look the way we're going to do, or the way we want it to look. Okay. I.e., there's less dose for the patient because you're not having to retake images, because you can change that image a little bit to make it look a little bit better. That was the problem with film. You take your image, go in the dark room, you take the film out, you put it in the processor, it processes, it takes a couple minutes, about 90 seconds actually. And then you look at your image and it's a terrible image, it's blurry, it's dark, it's light. So now you got to go back. Well, you got to figure out what you need to do to make that image better. You have to go back, you have to take a picture of that patient again. So we're re-radiating that patient. A lot of that we don't have to do anymore because we use digital radiography. That image is automatically up on the screen, no dark room, no chemicals, no processor. And like I say, if there's a lot of latitude, meaning we can change the window and leveling of that picture to make it look a little bit better, we don't have to retake that picture. The only time we should be retaking pictures is if we miss the body part and we've grossly underexposed the picture and we can't change it, because if there's not enough information there, you can't do anything with the post-processing. So anyway, that's two reasons for repeat x-rays, which we don't have to do very often. So in image storage and retrieval, all this digital radiography has come a long ways. It's all stored in a PAC system. Ours is one PACS by LSRT Radiology. They store our images for us. Before, you had to put everything in a folder and put it in a big file room, which was huge. And yeah, you get enough images in one of those files and they're pretty heavy. Anyway, we don't have to do any of that anymore. So radiology has come a long way. Just know the difference between CR and DR. CR, you have to use some sort of mode to take that image out of that cassette and send it to the computer digitally. Whereas digital radiography, you take the picture, it senses it, and sends it to the computer. Okay, pretty cool stuff. And then I just have a couple pictures of. So this is a digital receptor. On the Paxis 100 machines, it's built onto there, onto the actual unit, so it doesn't look like this. But some of the clinics in Boise, as well as Afton, you're going to see an image receptor that looks like this. The one in Afton has a cord on it. The ones in Boise don't. But that is what an image receptor looks like. Okay. So this is what I was talking about. having to put that cassette into a machine to take that image and convert it to digital. They kind of look like this, and I've used those a lot. You take your image, you take it, you stick it in this machine. It takes the image off there, sends it to the computer, and then it erases the phosphor. So you're ready for another image. Back in the day, when it hasn't been that long ago, this was the cat's meow right here. Man, if you had one of those, you were doing good. So, but we don't have to worry about that. So Sterling has done us right as far as X-ray goes, for sure. Okay, this is the dark room revolving door. Kind of cool looking. Yeah, you go in there with you turn the door and it opens up into the dark room. Okay. So this is what a dark room looks like. There's usually red lights, so you can see a little bit, but it's actually darker than that. There's usually one red light in there, and the reason they use a red light so it doesn't expose the film when you take it out of the cassette. Then you put it into a processor and it runs it through there. Yeah, all the film was kept in a big drawer, different sizes, and if you left that drawer open and somebody goes in there and flips on the light, you're in big trouble. You're talking thousands of dollars of film exposed. So yeah, it just wasn't a great time. You learned how to do X-ray really well though, because you didn't want to do a bunch of repeats. So okay. So that's it for today. Radiation safety is no joke, Jim, and that's for sure. And we'll talk a little bit more about that. And I promise you guys we'll get more into the nuts and bolts of mass and KVP versus size of the patient and what we use for them. Anyway, I appreciate you guys being here today. I hope this was helpful. If you have any questions, please reach out. I'm definitely here to help. And as you guys start to get ready for a test, I just hope that you'll use me as a resource and I can get you headed in the right direction. Anyway, thank you guys for coming today. It's nice to see, one of your faces anyway. Anyway, thanks for being here, and we will talk next week. Have a good one.
Sure.
Hey, no problem. Drive careful, Noel.
Bye.
Thanks, Eric.
You're welcome, Kate. How are you today?
Good. How are you?
Good. Hey, Kel.
Look at your Evanston team.
I know, representing. Dang it. Good job.
Yeah, I'll talk to you later.
Okay, see ya.
Bye.
Bye. See you, Kel.